Hey, Dr. Ganguly, how are
Hi,
you?
very good, Dr. Anwar. Good to see you again
Good to
after a
see you.
while.
Yeah, very good. Yeah. So, how is New Orleans?
It's it's uh it's getting better,
Yeah,
but that's only because of the social distancing measures that have been put in place.
yeah.
Uh,
Well, I want to give our audience a little bit time to join in. I'm Dr. Anwar, and I've got Dr. Ganguly on Instagram Live. She responded within like 3 minutes because Nadia has gotten tied up in the ICU in New York. So, my goal was to talk to somebody who's in one of the hotbeds of COVID-19. And Dr. Ganguly, or Shita, who I've known for several years, is now a fellow in New Orleans in infectious disease. So she's in the center of the COVID-19. New York and New Orleans are hotbeds where there are lots and lots of patients with this dreaded condition. And we just wanted to kind of go over that. I'm in Dallas right now, and we've got um, lots of people who want to hear from you. So tell us a little about you, where you are, and where you came from, and where you trained, and
yeah, so as you know, I grew up in Texas and did med school there, did my internal medicine training in New York. Um, which was challenging on even in the pre-COVID days, so I can't imagine what it's like now. And then I moved to New Orleans about a year ago, um, and I've been enjoying it up until very recently when things have changed, but uh, it's been now part of being an infectious disease. I see a different uh, challenge than internal medicine. I um, Right now I'm working on a lot of projects. We're doing post-exposure prophylaxis studies, observational studies um, to see what underlying conditions may have played a part in some people doing so much worse, especially in New Orleans, where I'm sure you've heard that the demographics have really affected certain populations more than others.
right. So you started your fellowship in New Orleans what month
In July
of last
of,
year? So
of
you're about
2019.
8 months in. Okay.
Yeah, yeah.
Yeah. So you're uh, when I was doing my residency, we just got involved with AIDS at that time, and
Mhm.
it's a very harrowing time. So you've seen a lot of patients in the ICU, um, and in your experience, what type of patients are there? What ages are they? What,
It's been a range. I was so surprised. In the early days, there were a lot of so service industry workers, Uber drivers, mail carriers, um, a lot of nurses. Uh, I mean, even now, EKG techs and transport people. We supposedly we have tried to cohort patients into COVID and non-COVID units, but even with those measures, we're seeing a lot of general hospital workers get sick and get admitted to the ICU. Um, as far as age, it's been varied. Uh, in their people in their 40s, uh, up until 80s, 90s, but quite a few people in their 40s and 50s. Otherwise, who are healthy, um, most of them do have high blood pressure, but some don't have any other underlying medical conditions. So typically I remember a couple of years ago we had the flu pandemic or epidemic in New York, where everyone had influenza, or ICUs were really stressed at that point. But that demographic was different. It was expected to see some 70 or 80-year-olds on.
Oh, they were older.
Exactly,
Yeah.
but not this seems to be less discriminatory.
Sure. Are you surprised by what you see versus what the news was saying a month ago?
Yes.
What are the surprises for you?
So I remember reading the early reports out of China. Um, a lot of people who were in their 50s or 60s, and at that point, there was a lot of ex interest around high blood pressure and ACE2 receptors. Um, but now I'm seeing a lot of people in their 30s um, who are also getting quite sick. Most of them seem to be working in healthcare related fields, so social workers or uh, medical assistants. Um, but I wouldn't expect something to affect 30 and 40-year-olds so drastically.
Yeah, yeah. And so, what is your
And the other thing that, which is really unique, with influenza patients who get very sick and intubated, uh, the the sequelae of complications is seems to be different than what this patient population is seeing. We're seeing a lot of uh, multi-organ failure. They seem to be pro hypercoagulable, so they're developing DVTs. Um, Several of them, they seem to be improving. Um, they'll pass their spontaneous breathing trials, and then they'll crash the next day.
so a different presentation than the flu patients
Yeah.
when they get sick? Um, in the ICU setting, when you enter the room or other people enter the room, what is your gowning procedure and coverage and just describe the equipment that you have to go in when you go in and when you come out.
So you wear, we've been doing a set of gloves first, and then we put on the gown. Before that, we put on an N95 and then a face shield. The ones that we have also have another surgical mask attached to the N95. I'm sorry, to the face shield. Then you, uh, and then the surgical gown. We don't have any protection for hair or shoes.
You don't.
Hmm. Some people, it's not part of the standard, um, I guess, protocol, but some people do independently wear bonnets.
Yeah. From what I, I'm not an infectious disease and I'm not seeing these patients, but from what I've read, they should be dealt with more like a contaminated patient, right? Where you should have total coverage, and then um, there should be protocols for removing your N95 mask. Can you describe how you remove the N95 mask and also
So,
tell the audience that that's really where the risk of the infection comes into healthcare workers?
absolutely. And at this point, because, um, you know, I am just kind of reading whatever papers are being published. University of Nebraska is publishing a lot, and this is highly aerosolized, even in procedures uh, outside of intubation, outside of nebulizer treatments. Virus particles are still being aerosolized, even with nasal cannula. And some studies have shown that it can be, even in the absence of cough, um, viral particles can be detected out in patient hallways, 6, 8 feet outside of the door. We don't know if this poses a level of contagion, if it's pathogenic or not, but at this point, I'm just leaving my N95 on at all times while I am in hospital hallways. Um, Especially in elevators, we know that this can remain aerosolized for 4 hours. So who's to say that someone sneezed or had a conversation in an elevator at 4 hours ago, and then you're getting into one now that the virus is still not airborne. So I'm leaving it on. They have, luckily for me, because I'm a consultant, I don't have to spend 8, 9 hours at a stretch in the hospital. I can do most of my work on through remote access. So I think you can leave it on about 4 hours continuously before you start having issues with perspiration and fit. Um, but you're absolutely right. Taking it off is just as it's more important than putting it on. Most people seem to infect themselves when they take off, when they deg-off. But that's why I use two gloves. I discard the first set, and then the one underneath is what I usually use to take my mask off after I have used sanitizer.
Right. It's recommended to have two people,
Mhm.
somebody helping you to take your mask off.
Yeah,
Is that practiced?
no.
No. So, all right. Um, I've got a little bit of a bias in that, our healthcare workers are not doctors, nurses, they're not getting the right equipment. I mean,
Hmm.
that's kind of known. There have been some nurses that have walked off. Um, and by the way, I've heard that the N95s are re-sterilized, that you have to reuse that unless you have your own.
Yes. So, but I don't think anyone has enough supply to keep using a new fresh one every time. So
Right,
they do have sterilization practices
right.
in all hospitals now.
And how does it re-sterilized N95 feel like? It feels different, right? I mean, it doesn't feel like the original.
Even, if you're reusing a mask, yeah, it doesn't quite feel the same. You could theoretically get fit tested again. In our hospital, they do fit testing around the clock. So you can
Okay,
just call someone and um, they will come to wherever you are to do a fit test, which is especially important because a lot of people are donating PPE and you're having a hodgepodge of masks. So, uh, I'll be honest, I didn't get I've been fit tested for certain types of masks, and once those have run out, I'm using a different one, and I have not gotten it fit tested yet.
how do you do a fit test?
Basically, you put on the mask, and then they put a hood over you um, that looks it fits around your shoulders, and then they spray some material underneath the strap, but they haven't figured out why some people are more um, maybe still virulent without having symptoms. I think they tested uh, a number of people on the Princess Cruise line, and quite a significant percentage of them had never displayed symptoms.
Wow.
It was in the tens. I can't give you an exact number, but it was definitely around 20%,
Right.
maybe more.
So if they don't have symptoms, just the act of speaking, the viral particles are beginning to circulate, and that's why the distancing and wearing masks are critical. Uh,
Right.
People.
Yeah. But even, I think the 6 feet is arbitrary. Um, there a few lab studies, a few um studies that were sponsored by the National Academy of Sciences um, did show that the virus could go beyond 6 feet. Um, they haven't replicated these studies and um, uh, validated it multiple times yet, but it's still young, so we don't know if 6 feet is really enough.
Right. So in the ideal world, um, what would for hospital workers, let's say a
Yeah,
respiratory therapist like Nadia who couldn't be on the
yeah.
call today because she's busy, what should their protocol be? Um,
They should dress exactly uh, how China did it. Um, there is a very nice document that shows their exact donning and doffing techniques.
so
I
wait,
think,
start. Yeah, we've got a lay public out there, so
oh,
gown,
sure. Donning. So
donning,
donning is
and
putting,
doffing.
yes, donning means putting on your personal protective equipment, and doffing is taking it off. So in China, they had, first of all, they were completely covered. And then they had partner systems. They would have shifts of 4 to 6 hours. Um, there was a contained unit that they would enter. Nothing was allowed in, and including cell phones. Um, I think somewhere I read that they wore diapers because they couldn't, once they were in, they couldn't go to the bathroom or they'd have to wait until their shift was ending. And then they'd do their work for 4 hours, come out to a separate station with the assistance of another person, take off all of their protective equipment. And then those workers were quarantined for at least 14 days. So as long as they were working, they were kept in a separate hotel room or separate quarters from the general public for at least 14 days before they were allowed to go back into society. I think at this point that might not be so feasible, but I do think we need more protective equipment than we have. I do not believe that um, an simple surgical mask is enough to protect people, even when you are not doing aerosolized procedures. I have a cousin in
Can you repeat
England.
that? Can you
Yes.
repeat that?
So I do not feel that a simple surgical mask is enough to protect uh, healthcare workers from contracting COVID because it's so aerosolized that it can penetrate through the surgical mask. And I have a cousin in England who's an emergency room physician, and she said that they were not allowed to use N95 masks, and she has COVID now, um, despite only going to work and social distancing and everything else.
Yeah. In a lot of hotbed cities, um, what is the rule for healthcare workers when they leave the hospital?
There's not really a rule. Um, we are still under a lockdown, so um, basically, we're bound by the general public um, rules.
Right. So you change if you've been in the ICU for several hours. Let's say a respiratory therapist who's at the bedside for 8 hours. They're not required to change clothing or shower before they leave the hospital,
No,
and they just go to their car. They may go shopping afterwards.
Yeah.
I would think that they would be highly infectious.
It's a possibility, yeah.
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 Okay. All right. And so tell me, in your setting, are medical students allowed to see patients?
No, the very first case we had, unfortunately, a handful of medical students were exposed to this one patient um, who was eventually diagnosed with COVID. And once that came back positive, we did a lot of contact tracing. We sent those students home, and we stopped all. The next day, we sent all medical students. Um, they stopped their classes, and they've been helping us chart review and help get us PPE. So they remain busy, but they should not be in the hospital, I think.
Okay. How is it in New Orleans now overall? The number of cases flattening out,
It's
increasing,
Yeah,
decreasing?
it's going down a lot, but that's because we've been in lockdown for almost 3 or 4 weeks again. Um, our ICUs, there's still a significant number of people on the vents. Testing has gone down. Um, Overall, I would say that people have been quite obedient to the rules, and it's been effective. But I'm concerned about when these restrictions are lifted or some of these, people hear that, oh, there seems to be less infection. That must mean that it's going away. I don't think it will.
Right. So what do you think is going to happen when the lockdown is removed in New Orleans?
So as of now, they have extended it until I believe May 17th or May 27th. Um, and I just saw that Trump has done a phase by phase plan. First, uh, allowing, each step is a little less lenient than the last. And I think Dr. Fauci recommended uh, carrying out each phase for 2 weeks and seeing where the trend is. But I don't think that this is something that can be eradicated at this point. It's out in the community. It's ubiquitous, almost in the environment. And unless there's a vaccine or you have antibodies, and we can prove that those antibodies prevent you from getting reinfected, um, we have to remain on guard.
Right. Um, have you looked at what's happened in Italy, and can you predict from that what might happen in New Orleans?
Uh, I think it's too soon. I think they um, maybe I don't know if they have lifted their restrictions. I know Germany has eased its restrictions. So looking to that might point to where we're headed.
So
Um,
Germany would be an area to keep an eye on.
yeah, although I think they've done better at mitigating it than we have. At this point, testing is, everyone talks about testing. And by testing, I mean the PCR, the detection of active disease.
The diagnosis, putting the swab down the nose and all the way back.
Right. That, in my experience, has not been perfect. Um, and we don't know the true uh, how efficacious it is in diagnosing disease just yet.
So you
So,
you could have false negatives.
mhm. And
Uh,
I've seen it quite often.
So a lot of the time you could be COVID positive, but the test is negative, the diagnostic
Yes.
test.
And I think that's
Yeah,
far more dangerous than if we had
because
a
you're kind of
because now you have this false sense of false reassurance that you do not have the disease.
Yeah. And describe the technique, and the technique is super important. You got to get way back there.
Right. So basically, it's a really long cotton swab, and you insert it all the way back. It almost feels like it's tickling your brain. It's very uncomfortable. And if it doesn't hurt, or is if it's not if it's comfortable, then you probably did it wrong. Um, and there are different techniques. I think yesterday they came out with a saliva test. Rutgers did, and uh, some studies out of China showed that maybe sputum is more sensitive than the nose. Um,
What
so
kind of sputum? Which sputum is?
just a
Just
sputum
sputum?
study. Yeah.
Hmm. Okay.
So maybe an oropharyngeal sample.
Okay.
Yeah.
And how soon before you get the results? How many minutes?
It depends. So I think Abbott is a 45-minute test. Um, the Roche, I think, takes a day to come back. So they have various turnaround time, and we've been given at the hospital guidance on which patients should be given which test, depending on
Right.
where they are. Inpatient you can wait a day, whereas in the emergency room, you'd want the higher turnaround time or lower turnaround time.
So we've been talking about the diagnostic test. The patient could be COVID positive, but the test turns out to be negative
Mhm.
for a lot of reasons. And I imagine that's the reason where there are cases that are considered to be COVID positive with negative cultures and on the death certificate. Um, so what do you think the deaths are being inflated, the number of deaths?
I think they're being underreported, actually. A lot of
What?
people were dying. Uh, um, People had viral illnesses in February. People were dying of double pneumonia, whatever that is, um, in February before we had our first confirmed case in the middle of March. So I think it was already out in the community before we were detecting it. Um,
Is that still the case? That it's being
I
underreported?
I I'm not quite sure. Um, how, one thing that might be helpful is to compare this year's death rate to last year's and see how many more people died of respiratory symptoms. Influenza season uh, has ended now, so that information should be easier to uh, elicit. But I do think that overall the number is lower than the true value that's reported.
You think that the reported what is lower?
That the reported number of deaths is lower than the actual number.
Okay, so actually, you think more people are dying from COVID than being diagnosed?
Sure, yes.
Right. Okay. All right. Now, um, 2 months ago, when they on in China, and a month ago, and did you ever imagine that New Orleans would be a hotbed like it is?
I didn't. I was still hoping that this was seasonal, and we had a very winters over here are very mild, um, and humidity seems to be helpful in preventing the rapid spread of this disease. So I thought that we wouldn't see the numbers, maybe a few cases, but not to this extent.
So are you? And I think other cities should probably, uh, well, like Dallas doesn't have a lot of huge number of cases. I mean, we had like 20 to 30 at Park at the medical school and 20 to 30 at Baylor at the height, and
Mm,
the hospitals don't have a lot of cases, but also the hospitals are now empty because elective cases and so on are not coming in.
yeah.
So you could get a false sense of security, I imagine, in a place like Dallas is a big city.
Yeah, yeah. We I do think that Mardi Gras had a huge hand in the number of cases that we saw. I think it was already in the community, but having a million people from all over come into our city and then celebrating um, in crowded environments made it spread.
Okay, yeah,
And then the city's underlying comorbidities, obesity, diabetes, high blood pressure, um, all of that made it a very fertile ground for coronavirus.
yeah. Well, New Orleans has the best food, and
Oh,
Louisiana, San Antonio, Houston has highest obesity rates, and heart disease and all that starts at age 8, 9, 10. With the Bogalusa heart study, they showed that fatty streaks and all that starts at age 9 and 10 years old, and a lot of the lower socioeconomic groups. Well, why do you think, besides bad overall health, are there any other reasons why African Americans were more impacted?
I think a lot of, especially the ones that I've seen, they work in service industry, so uh, in restaurants and uh, Uber driving, any profession that you deal with a lot of contact, multiple human contacts. I think for those reasons, um, maybe people have been more exposed, and also um, New Orleans is a pretty expensive place to live, actually, and not everyone can afford their own home, so you have multiple families living in the same setting. So if one is sick, then surely the whole family will at some point become sick.
So crowded and a lot of underlying conditions. They probably show up pretty late too, because probably a lot of maybe people don't have insurance. Is that a big issue?
It um it might be, I think. So one of the hospitals that I work with was the center of um, it's built this 200-year tradition on serving the underserved are uninsured, and maybe they are more afraid to come in. But I haven't seen any large studies to really pinpoint that.
In in my experience, people with lower socioeconomics just are they're often afraid to come in. Sometimes they don't trust the system, uh, and I think, frankly, that they're probably going to be afraid of the bills as well. Uh,
Yeah.
how about smoking and vaping? Do you have any opinions on vaping?
I have not seen any correlation, um, but that's just a snapshot regarding smoke. A lot of the patients that I have don't have a smoking history at
Right.
all.
So, what kind of people that work in the hospital, are there certain groups that you would say, you probably shouldn't be working in a high COVID infested hospital? Who would you send home? I try to send you home. You've got asthma. Didn't work.
I um I think based on, what we're seeing now, it seems that high blood pressure, uh, diabetics, obese, underlying lung disease, um, frequent infections, um, all of those pe we have to change the way that we practice. I our stethoscopes were our you know, I felt so naked without having that in my hand. Now I haven't used it in 2 months. I don't know if I when I'll start examining heart and lungs again. Um,
Because they're
it's
dirty?
more of a danger to the patient at this point to use. Because you have to get very close to a patient to listen to them. With the COVID patients, you know, oftentimes their lungs sound fine, so it doesn't really help you. Um, but uh, we
Can
have
you
to
repeat that? We
employ.
didn't understand that. We kind of lost you for a second with COVID.
Sorry. Their lungs don't sound so bad. You don't hear a lot of rales, you don't hear rhonchi, you don't hear wheezing. But when you look at their CAT scan, you're blown away.
Yeah.
So the findings, your physical exam findings do not match
Right.
uh, the underlying destruction going on.
Would it be helpful for the public to see more X-rays from COVID patients to kind of like show the level of seriousness?
I think so. I know that a few physicians who were admitted to the ICU were posting it on Twitter, their CAT scan findings. I think, uh, you know, I have some photos, and whenever I show anyone, they're amazed. Um, right now, but oftentimes the X-ray um, looks poor, but not so alarming. But the CAT scans are really, really impressive. At this point, we have early on we were getting CAT scans on most patients. At this point, we've stopped doing that because we know that it looks poor, and then cleaning the machine is burdensome, and it doesn't change clinical outcome that much. But yeah, you know, a quick Google search will show you
Yeah.
how bad it can look.
Yeah. Yeah. When I look at those X-rays of cardiologists, it just really concerns me. It scares me. I mean, we're not used to seeing that kind of pathology, that type of an X-ray where you've got infiltrates everywhere, or CAT scan. It's just
Right,
not
and
compatible with life.
yeah,
It
and
is a
those are
common
those are
finding.
patients with those are patients with ARDS, but even patients who have, let's say, milder symptoms and are not intubated, their CAT scans look horrible.
So even the milder cases. Yeah,
Yeah.
yeah. So let's shift gears. What about serology? What are your feelings about that? And is that going to be? Um, I just
So
realized I touched my nose. So I'm going to put a little product on it. Uh, so we touch our face 2,000 times a day. Acceptable. Anyway.
yeah. I'm no expert on serology, but from the
Hey,
meetings
you're
that
the
I've
most
been in.
expert here. You're an ID fellow, so you know more about that.
So it's at this point, you know, one of the attendings, uh, you know, they said they're garbage at this point, because a lot
They
of
say
them,
they say serology is garbage.
some of the tests out there, because they have
Yeah.
not been, um they're not confident that it can distinguish from this coronavirus from other coronaviruses.
Okay.
So maybe you had, you know, one of the mild coronaviruses that causes less severe symptoms, or if you had SARS, um, your IgG might be positive, but you have not been exposed to COVID-19.
Okay. So, are there COVID-19 specific serology? Not.
They're working on that. I think there's um, you know, dozens of companies out there now who are coming up with antibody testing. Um, and I don't know the exact numbers, but it seems that they're having some trouble initially. Maybe they'll be able to. I'm sure they'll be able to figure this out with some time.
Well, that would really shoot a hole in a lot of theories, right? If the serology is not specific for COVID-19, that coronavirus, then um, it's pretty hard to trust that you're going to have immunity
Yeah.
going forward.
And we still have to prove that having antibodies confers immunity. That is still under question. I have some papers that I need to review tonight. Um, there seems to be some people who get reinfected, but I have to look into that a little bit more before.
Okay, so serology um, not solid.
Maybe at this stage, not yet, but maybe we'll get there. We
Yeah.
should get there.
Well, we don't really have much of
Have
a
an
choice.
option. Yeah.
So then, for now, we should assume that everybody's still infectious, and um, be careful on the loosening up business.
Yeah.
Yeah.
This is gonna be
Do,
until
do you think the
there's a vaccine.
coronavirus in New York and California were similar, or they seem to behave completely differently?
I think in New York they had done gene sequencing and showed that it came by way of Europe, whereas on the West Coast it was linked to China. Um, we know that the virus does mutate.
Does
Um,
mutate?
so
You're
it
I
does,
mean,
yeah.
where you are is a very strong infectious disease center, right? I mean, it's a world class ID place, right?
Yeah,
I mean, yeah,
a lot of the focus here has been on Ebola and tropical medicine. But I do have a professor who's an expert virologist. Her focus up until this point was on dengue and chikungunya. She has shifted all of her gears into COVID now, and even developed in-house testing for it very early on. Um, but I think this will continue for um, as soon as we start easing up significantly, I think it will come back the way it did.
so if you lived in Dallas, when would you go? When would you allow in New York? When would be the earliest that I could go there?
I love New York. I miss it all the time, but I have no plans to go there. Um,
How long?
Definitely not this year. Maybe not even next year. But I have asthma. I've been um, multiple times in my life where I thought I would die from respiratory distress. So I am hyper vigilant, and I would avoid all unnecessary travel there. Um, I'm thinking of, what I can do to occupy myself for the next 2 years. I'm getting comfortable at home and, using technology to connect uh, with friends and family. But I am very wary.
Yeah. Well, good. So, do you want to give me your list of surprises from a month ago to now? I mean, like what are the discoveries? I have so many discoveries myself almost every day that I
Yeah.
um,
The, one of them would definitely be how infectious this is. Um, and seeing people just can be talking in a room and become infected. There was a choir group in Seattle of 60 people, uh, of which I think 40 became infected, and two died. So this thing lives in the air for so long. It can live on surfaces for so long. It's so uh, pretty sturdy. And then just how virulent it is. Um, I know some people who had it and had very mild symptoms to just loss of taste, loss of smell, to um, others that were intubated on ECMO, on heart-lung bypass machines. Um, it's very surprising to see how the same virus can affect people so differently. Another thing I've been very surprised about is, I thought I would be more protected working in the American healthcare system. Um, I think until we know the exact mechanisms, uh, we have to do everything we can. We have to be overcautious. I think the CDC putting out a statement saying that in the event that there's no N95, you can use a bandana or scarf was dangerous. It should never have been said um, because after that, hospitals started changing their policies and telling people you don't have to wear an N95 mask unless you're doing aerosol generating procedures. Um, so at the end of this, we really need to um, question what knowledge uh, is placed, and then also question guidelines. We need to, um, as rapidly as this is evolving, we can't just trust the guidelines. We have to be ahead, and we have to analyze papers ourselves and make our own conclusions. Um, and then after some time, rely a little bit more on guidelines.
Great. Well, I really appreciate your time, Dr. Ganguly, and your dad getting you on the phone within 4 minutes notice. Thank you. We will find, um, we'll find Nadia at another time. I am so appreciative, and I admire your dad and your father, both great physicians. I've told everyone that your dad is like the best doctor I've ever seen.
I
And
feel the same, yeah.
yeah, he's just incredible, and your mom as well. So I'm gonna let you go, but I'll be in touch. I want you to send me some of those articles, and maybe
Yeah.
we'll beat this in a few weeks. And it's so awesome to have a young technology savvy ID doc on the line. So Dr. Ganguly from New Orleans, thank you so much.
Thank you, Dr. Anwar.
All right. Hey, do you know
Uh,
how I'm supposed? Okay, I'm gonna end this, and then what am I supposed to do? End it and then record
um,
it.
I have never actually done. I've never been on the
You've done
opposite
okay. I'll
end
figure
of,
it
yeah.
out. But by the way, somebody asked about a BCG vaccine. Do you have any thoughts on that?
I I think I saw. I haven't read the specific papers on that yet.
Okay.
Yeah.
Yeah. Yeah. Okay. Hey,
Uh,
triple Ganguly doctors, we love you all.
all right. Thank
Okay.
you.
Take
Bye.
care. Bye bye. Stevie, tell me what to do with this, and then hit the save button. Okay. Oh my God. Okay. End and then save. End it.